And welcome back, folks. This is House Corrections and Institutions Committee. It's Thursday, February 26th. We're going to be spending time with the Department of Corrections to go through their fiscal year 27 budget proposals. This is what Appropriations Committee is working on. And we being the policy committee for DOC, we will be able to weigh in. Appropriations Committee this particular budget. So welcome. Start out with the commissioner. You can introduce yourself and then go from there. Once you get settled.
Apologies.
No, that's fine.
Good morning, everyone. I am John Murad. I am the interim commissioner for the Vermont Department of Corrections, and am very grateful to be here.
I'm Marlene Batty. I'm the Executive Director of Finance for the Department of Corrections.
Okay. So what I know your documents right here are ups and downs, which that helps but doesn't help because we don't know what the base is in terms of what you're going up from and what you're going down. But you do have some additional sheets in the back, which is, I believe, a reflection of some of the questions that we asked in the work that 5 members of the committee came up with. So
Yes. I think most of this is a response to that document. We certainly didn't get to, it was a large document that you all prepared. We were grateful for it. It was also very, very wide ranging. It touched on a whole host of different parts of the DOC entity and enterprise. And so we've gotten to as many as we can. I'm certain that there are going to be missing pieces in this. And if you have missing pieces that are specifically important to you, that were on that sheet, but that we failed to get to, flag them, and we will do our best to get to them as well. But we did get to quite a few in this document. So I think we can start looking at them sort of as they sit. We went essentially through the document that you provided in order and question by question that was posed.
That's great. So why don't you just start with these ups and downs and then we'll get into those questions.
Would you like me to go through the payroll ups and downs as well?
Quickly.
Okay. All right, so starting with B 335, appropriation with 1,000 ending, the ups and downs for that subtotal of the increases is 692,712, which is all salary increases, benefit increases. Then the next section, which is the parole board.
You know nothing about the parole board.
We've had testimony on it.
Ah,
So as you can see, most of it is the salaries, but there is a decrease for the fringe benefits is probably somebody that made a change. And so that just calculates automatically within the system. For parole board, that $25,000 decrease was because we were not able to secure a private counsel. And so that's the $25,000 decrease.
So I just want to be clear, the 25,000 that got zeroed out for FY 27, the 25,000 for legal counsel is still in your FY 26.
Yes.
So for the parole board, your yearly budget for FY 27 that you're proposing is 607,000. Any questions on this one from the committee? Okay.
The next section is B 337, and it's correctional education, community high school. That is the subtotal of increases and decreases is 328,551, which is due to salaries and benefits increases to the natural process. The next section is correctional services, which the salary and benefits increases are listed here. There are some additional ups and downs that have to do with specific programs. The first one is pretrial supervision for statewide expansion of 200,000 after the salaries and benefits.
Do that again. So I was looking at something else.
Sure. So the first section is the salaries and benefits and any changes that are made.
Okay.
And then, the next, the 506200 is pretrial supervision for statewide expansion. It's 200,000. That's the remaining 200,000 to fill for the staffing that had been put in place.
Is that for current staff or it says expansion? So it's
With that,
expansion.
well, when I say expansion, it's for those 11, what is,
Oh,
12 positions. So it's for those 12 positions. So from our financial CFO at AHS, what she told me, gave me for budget allocations to fill all the positions that we currently have out there that may not all be filled is FY 25, there were 660,766. FY 26, there was 650,000. And then this year would be the last plugging of the hole for those positions, which would be 200,000. Those were, the first two were base and this last one would have, of course, been 2. And that was for those 12 positions. Because I did not fund them all up front.
right. There's 5 positions currently that have been funded for that. And what is the cost for those 5 positions? Do you have that?
I have, one is 141,000 and the others, most are budgeted at 118. I only have, some of these were vacant at the time too, so they were budgeted 118. And one that was filled is 114.
The total, because I just did the math with a calculator,
Thanks.
it's always a good idea, is 610,462.
So 610,000 for the current 3 or for the 5? So that comes out of the 660 from FY 25? Or does that come out of those 650 that got added on in FY 26? Or the out of the total 1.3 million?
Well, all of those are rolled into the total 1.3, are they not?
They were hired in different years, so that's why.
Right, and we didn't have full funding in those years, so that's.
So your initial funding was in FY 25 for 660,000. And the authority was you could hire 5, you had 5 positions. That was the beginning. So from, just trying to remember here, probably from the fall of 24 through the year of 25, calendar year, you've hired 3 people for the pretrial supervision. You hired someone in Newport, you had the Burlington, and the St. Johnsbury. So you've got 3 positions with Bennings. So how much is that right now? Do you know?
I think that's the amount that Haley quoted.
About half of it.
Yeah,
$374,082.
So 375,000 for those 3 positions.
Yes.
So just looking at cash flow here. So out of the 1.3 million, there's $1 million left. Basically, 900 and some odd thousand left, because you've already expended 375,000. And out of that 950,000 that's left, round numbers of the 1.3, you can hire 2 more people that would come in at what? 200,000?
A little
300?
More than that, but roughly.
250?
Two with fringe, two individuals with fringe is a little over two
It
hundred.
would be about 236.
36?
Budgeted amount.
So that's your 660,000.
Well, 610 of it, right? Isn't that the number that Haley quoted? The 610 is the 3 plus the 2.
Yes.
610, right, for the 5.
Out of the, yes,
So out of the 1.3, you take 6.610, so you've got 900,000 out of that 1.3 million left, pretty much.
7, right? 1.3 minus.
1.3 minus 6, 7. Never do math in public.
690, closer to 7.
So 700,000 out of that. And then I'm just trying to follow the money here. So you got 700,000 left. And then you've got another 1.3 million in your base for pretrial supervision. And then that 200,000 on top of that,
In this year's budget would be the add.
FY 27. Right? So the 700,000 that you've got left of FY 25 and FY 26, you've got about 700,000. And then you've got an additional 1.3 million in your budget for the pretrial supervision. And then there's that additional 200,000 on top of that. So you have 1.5 million on top of those 700,000. And that would be to fund,
Yes.
No, I don't believe that 200 is on top of that.
The 200. Okay, so for the pretrial, the positions themselves for all 12 were budgeted with the ones that were filled at the time at 1.4 million. And so that's with the 5, that would be as you said, the 610, and then you'd have 700,000 left of the 1.3 that we have been given for those positions over 2 years without the 200,000 requested this year. But there isn't an additional amount on top of that.
so the 200,000 is within the 1.3.
No, it's in addition to, it would
So
be
it's 1.5.
1.5, yes.
Then you got
That's all for
700,000 from previous appropriates. So you've got 1.5 plus 7 is 2.2 million.
The money from FY 25, that went into pay act, correct?
Yes,
So that's
It's a
not money
payroll.
that's laying around.
From FY 25.
Yes.
So six. So how much should you have in FY 26?
that we received for pay was 650,000.
Have you used any of that 650?
Well, we've used whatever we have,
For the people that we've hired and the time
Right.
with which they've been and the time that they've been with us. So, each of those individuals was hired at various points in the FY. And therefore, one of them actually may have predated the FY. One of them may have been in FY 25, but the others were hired during FY 26. And, which obviously, still in, and therefore looking at, that money we're spending it on those people.
anything that's not been spent is more likely calculated in vacancy savings when that is calculated.
So of the 1.3 million that you have in FY 26, because we're in FY 26 right now. Of the 1.3 million, how much is left of the 1.3 million?
Well, what would be remaining would be anything we haven't spent for these positions that are vacant. And that's within the budget itself, it's within the 4,000 in this section. So all the payroll is in there. But But yes, in answer to your question, out of the 1.3 by the end of the fiscal year, whatever we haven't spent for these positions is what we would have left, which we just went through.
That would get added on to the base that was 1.3 million plus the 200,000 that's being requested here for the expansion.
We would have, sorry if I'm not following you properly.
Well,
We would have 700,000 left before the 200,000 addition.
right, but you also have that 200,000. My understanding is that what's in your base budget for pretrial supervision in FY 27 is your base at about 1.3.
Right.
The 200,000 is on top of that.
That's right.
So you're at 1.5. And then whatever you have left over from FY 26, which could be about 600, 700,000, is on top of that 1.5.
Well, mechanically, how it would work is that anything that we have within that 4,000 is also offsetting other costs in there, as there's no restrictions allowed around it unless there were restrictions put on that. So if we were required to pull that forward, then we would need to know that so we could separate it and do it as a carry forward, if that was what was required. But generally speaking, what happens is any place you've underspent will offset a place where you've overspent in the budget, just so that you can, have a.
So you can move that money around to other,
Only within that section, that 4,000 correction services.
right, only within this particular section.
Yeah,
You could pull money out of the pretrial supervision to fund other items within this section.
We could, really what it is a matter of looking at the bottom line and seeing where you're at, unless there are restrictions on the money and where the fund should be going. So that would be what would occur, just offsetting other places in the budget in that section.
Questions? Or is it clear as mud?
Well, 1.5 is clear. As far as the balance through FY 26, that's not clear.
It depends on when they were hired, right, Joe? Because that one guy just got hired recently up in St. Albans. That's next to
No, St. Johnsbury.
Sorry, St. you correct, St.
There's
James.
3 that's been hired.
Yes. The one just recently.
So for those folks that were hired for the pretrial supervision, do you know what their classification was? Is it just P&P officers,
They're PPOs,
which is
probation and parole officers. I apologize. Yes.
And that's how they're classified. So they could be used for other functions within between the probation parole office in your field offices. They could be used for other functions besides the pretrial supervision.
It would depend on their caseload, but it also, the people that we hired are not necessarily the individuals who are going to do the pretrial. Pretrial may be, as we've said, and I think as Deputy Director Marvel made clear, the kinds of folks that would be good at this oftentimes are people with a little bit more mileage under their belt. And therefore, while the money is allocated in order to have, we have a total universe of caseload at each P&P office. And the additional person is coming in because of the anticipated expansion of that total universe, adding a new function, that being pretrial. And therefore, who does that new function is somewhat fungible. The people are at least.
Yeah, so like Commissioner, we were worried about that yesterday because if pretrial does disappear, we really don't want to leave people in the lurch who have come on board here. And I think it makes me feel better that you said that they're P&P. It's not like a new position, pretrial supervisor that necessarily disappears. It sounds like, you have enough work and you would have enough funds if we funded the 5 positions there. So that wouldn't necessarily result in a riff of those employees if pretrial disappeared. Is that right?
If there were a change that maintained the amount of funding for the positions we've already hired, then we would not need to change those employees or
Okay.
move those employees. that said, it continues to be the department's belief that there is a need for and a value in the pretrial rollout to all of our offices. And that is something that we still want to try to achieve.
We're trying to figure out, as you probably realize, between two committees here, we're trying to figure out how we go forward or not go forward with the pretrial supervision program for that. So that's right now, there's been no decisions made. So that's why we're asking questions.
Yep.
So we know how the money is flowing. You have authority right now to hire 5 folks. The 200,000 is in the governor's budget that's downstairs in appropriations committee with language to have the ability to hire 7 more folks. Yeah.
And the department is hopeful for those. That is the department's position as well as the governor's budget's position. That we want to make better progress than perhaps we have with regard to finalizing the 5. So moving past the 3 that we have and getting to 5, and then moving into the next 7 in order to have a person dedicated to this work at each P&P office around the state, all 12 field offices. And we believe that there is work for those individuals in this realm that is pretrial supervision, and that we will see that expand. In other words, we will see more pretrial use the more it becomes available in other places.
That's the goal.
That is our goal.
Yes. Okay, let's keep going. Then we can.
So under correctional services, B338. After the 200,000 is the sheriff's transports for expeditions, increased cost and volume.
So the sheriff transport for extradition. Is that your typical sheriff transports from facility to court, or is that extraditions coming from other states in?
Yes, the latter, ma'am. Other states, in other words, when a sheriff needs to go and get somebody who's been held in custody in another state, but is in one way or another either absconded from ours or is being sent to ours.
So is there a limit on where the sheriffs travel? Like if someone's down in Pennsylvania and they're extradited back up here?
The limit is the nature of the extradition. So, I mean, we bring people back when they are, when they're out of our custody. So, and they shouldn't be. But it's different than, for example, extradition for extradition for charges, that is not about DOC, but is instead about policing, does have limits. It has delineated limits on the idea of, delineated limits is redundant, my apologies. There are delineations on, for example, if you are wanted for a retail theft in Williston and are arrested in California, nobody is flying to California to bring you back for that single retail theft that is an open warrant or, a charge. An incarcerated person who is absconded is different.
Because they're under your custody.
Affirmative.
Okay.
The next item is WellPath staffing. This is the contract increases with the increased average daily population, and then the Burlington project. And the justice reentry revenue is the 801,823 under Medicaid GCF.
Oh, you lost us on that one.
Okay, so it's 2 things. Under GF is the additional cost of the increase in average daily population that went from 1,250 and to 1,550 is the top, but we're doing it. The rate's actually calculated at 1,500. And also the Burlington project, which is the substance abuse project.
which is additional, which is what we call enhanced treatment in order to be able to provide that as a means of additional service to people who were sent by the accountability court. It is not directly related to the accountability court. It is a service that DOC wants to expand to all of its facilities, but it began in CRCF and Northwest with the idea that it would serve people sent by the accountability court.
Troy.
Yeah, can I just get a little more clarification on that? I'm for it. Let me just start there. Given the testimony we've gotten from WellPath, the additional services in and around opioid use disorder, yeah, I'm for it. Why is it called the Burlington Project? This is a tangent.
That's the pilot project.
It's about the 14, it's about the Burlington 14 point.
Yeah.
Accountability.
That, the accountability court, the 3B court,
Yeah.
the Burlington 14-point plan from the governor, there have been any number of names that's just happens to be the one that's in this parenthetical.
How much of that 5.357 is going to the Burlington project? How far will that take you in the rollout of these enhanced care? And then is there anything right now on paper that indicates this is our timeline for expanding that to everybody in our custody who needs it?
The amount is 1.2 million out of that.
Out of the 5.
Yes.
And 3.
And I do, Haley, please correct me if I'm wrong or off on this, but we are providing this at Northwest and at CRCF, and it is now a component of our screening.
Yep.
And it is not limited to somebody who is referred to us by the accountability court. So in other words, I apologize that it says Burlington in this document because I believe that's a little bit misleading. If you're arrested in Williston or in Richmond and are sent to Northwest and are screened, this is something that now exists at Northwest. So it would be more accurate to call it a Northwest CRCF pilot project with regard to this enhanced treatment. And our goal again is ultimately to have it at all 6 facilities.
Right. So how far will that 1.2 take us at CRCF in Northwest? And is there a timeline for rollout?
It has taken us to Northwest and CRCF with regard to onboarding new clinicians, having WellPath hire these new clinicians that are able to do this work that we had not previously been doing, at least not in any real volume. That's how far it gets us. It gets us that, and it gets us that within this current contract cycle. So this, like any amount of money that we would be asking for any headcount, is something that eventually becomes permanent, right? And I think a similar sort of picture is when we talk about the pretrial pieces. Those are individuals that are hired in certain years, and it's separate money while it's a pilot, but eventually it becomes a component of overall correction services and staffing amounts of money. This would become an overall piece of the WellPath contract and would no longer be a separate carve out. But as we roll it, we will be asking for more each time we ask WellPath to provide this service at a new facility.
Gotcha. Thank you.
Or another facility rather of ours, not a new facility because we don't have any of those yet.
So are you delineating in this, I just want some clarity, in the St. Albans or the Chittenden facility? Is it available to anyone that's coming in and they are gone through the screening, there's substance use abuse that is determined, is this additional treatment available to anyone coming in through those 2 facilities?
I believe that to be the case.
Yeah, I would, however, just note that the person who is taking on this work was only hired about
A month
a
and a half
month and a
ago.
bit ago. And so at the moment, it's not yet scaled to the entire facility and that it's available to everyone. They're still kind of slowly ramping it up. However, it was not necessarily exclusive to that population that was coming in from the docket and Burlington when it was stood up, nor was there that mechanism for the court to communicate to WellPath, hey, this person is coming your way. Please ensure that they get this assessment. There was some capacity through DOC for that, but it was, somewhat not entirely direct.
So, I mean, of the 79 people that went through the 3B courtroom in Burlington, 61 of those ended up in DOC's custody or under DOC supervision. 22 of those are currently imprisoned, incarcerated. They have been sentenced. Their cases are now resolved. They've been sentenced. I don't know how many of those ultimately did or did not avail themselves of this service, but I also know that the service does not only exist for those 22 people. And that is our intention, and that is the agreement with WellPath. It was not something that said, we were never going to say, we have this thing that we believe is positive, is good, is moral, is a next stage in what Vermont wants to do with evolving how we treat substance abuse. And we're only going to provide it to people that come from this place.
So I know we've tried to schedule DOC and to talk about this new initiative. I think you're scheduled the week after town meeting.
Not officially, but that is the goal.
That is
We
the goal.
are working together.
Trying to bring you folks in, and between your schedule and our schedule, it'll get a little crazy. So we're gonna be looking at this more in depth after we come back from town meeting. Okay. I know you had a proposal for this, Commissioner, and it really involved the ports for this, but is that still where the department is?
I'm sorry, what do you mean by that, ma'am?
Well, the expansion of the substance use project. You gave me some documents for it, but it was really looking at the court sentencing these folks to this program. Is that still where the department's coming from?
No, in fact, our sense right now is that it's actually not a court prerogative to sentence folks to this. It's DOC's prerogative to provide it, and we want to provide it to anybody who needs it. So it's not really, I believe that it becomes, I don't want to get over my skis, as they say. I believe that it is a component of negotiations between prosecutors, defense, and possibly judges as well to say what is available while we're making these determinations. When we're saying, what would one take for a plea, or what is the best course of action here? But ultimately, it's not a component of a sentence. There is no sentence that says you shall be remanded to the custody of the Vermont Department of Corrections for 2 years because of this domestic assault. And during those 2 years, you will get X and Y and Z. That's the X and Y and Z is the prerogative of the Department of Corrections. And we want to ensure that among the prerogatives we have are as many helpful, caring, and rehabilitative capacities as possible. This is one such capacity.
So, and
But but I believe some of those were draft documents that I provided to you. And certainly we want to be fully transparent about what we're thinking as we work through, but I don't think it's something that's a court prerogative.
So, the other question for the folks here that can do the substance use treatment programming, are they also on MOUD as well?
In all likelihood, if you have this need, I believe that this is something that would only be provided to somebody who also is getting MOUD. Although, let me actually go back on that. This kind of treatment is not merely for those with opioid use disorder. If you come into our facilities with a significant methamphetamine addiction and are flagged for this kind of treatment, I believe this treatment can apply to that as well, whereas MOUD is not going to ameliorate the symptoms of methamphetamine, abuse disorder. So I don't think that it's just that, and I don't think that you automatically are on that if you are in this programming. But I would, for a definitive answer, I'd want to get that from WellPath.
No, that's accurate. It's not a component of the MOUD program. It is separate. However, it is likely that if someone is suffering from opioid use disorder and they elect for this type of treatment, they could be both on MOUD and receiving that enhanced services through WellPath.
So to receive the enhanced services, is there a requirement that it would be seen as medically necessary?
There is a screening that WellPath does. And, ideally, once it's scaled up, it will be part of the intake process. And that is how WellPath would determine whether an individual would be suitable for this type of treatment.
But to be suitable, would it have to be determined to be medically necessary?
That might be a better question for the doctor.
I'm just wondering if state statute might need to be changed a little bit for that terminology, because we do have a definition of medically necessary. So I don't know if there's some linkage there or not, and may not be able to take care of it this year because we're running a little late. But I think that may be something to check, because we are very clear for anyone that would be on the MOUD program. It would need to be deemed by a medical provider, a licensed medical provider, that it would be medically necessary. We're very clear about that. It's a medical decision.
I don't believe I've read that or know the definition off the top of my head, but certainly from my perspective, that is what we want. We want to ensure that any medication or treatment we're providing is necessary to the person who's getting it. And in fact, at least with certain kinds of treatments, medication treatments, not therapeutic treatment, but certain kinds of medication treatments, if we are not acknowledging medical necessity, you can end up with issues around diversion.
So then could you also explain the justice reentry revenue, the BAA item? I'm trying to recall.
Yes, so that 801-823, that's with the section 1115. That's money.
Oh, that's the 1115.
So that's what was calculated and estimated for 6 months.
That would be our cost that was like the IT with DEPA.
This would be Medicaid money we receive to help offset.
Oh, okay, because that kicked in January, right?
Well, so the way that works is January 1st, that program started, as far as people receiving the services and all that progress. But we have to report it out. And the way it's reported is it's after an end of the quarter, and then you report to Medicaid at a very specific deadlines. So we haven't reported anything, and we wouldn't be reporting anything. I'm talking about this year. Next year, we'll have it in place, but we haven't reported anything yet.
So is the committee following what she's saying? The 1115 waiver? 1115 waiver. 90 days prior to someone reentering the community for medical services that they're receiving while they're incarcerated is paid for by Medicaid. So that in some way frees up a little bit of DOC's budget, but it still has to be included in your whole WellPath medical piece. But Medicaid is picking up the healthcare costs of folks who are within 90 days of their release term. Prior to that waiver, it was on DOC's nickel.
Just to clarify, to reimburse it, so DOC still pays WellPath, and any potential reimbursement will go to DOC, correct? That's how it flows.
Yes.
And your first report is marked.
Our first report, it would be January through March. That we would collect this by quarter, collect the data. Then that process would actually be AHS Fiscal would then report that after we provide it in another format. They would report that in June. So it's, just that's when the actual, because it has to go through another system that actually generates what the correct amount is.
And have you forecast how much you anticipate?
The forecast is 801-823 for 27. And that was done 2 years ago when they first did the waiver. So it's an estimate at this point. And I think it might be, looking at that, the amount of patients receiving services, the number could be higher. So I think they did a conservative estimate, but I don't know yet.
Do you by any chance know what the number of folks are that are within 90 days of their release?
No, I do not know that. We could try to figure that out. Obviously, it would have been used in the calculation that Marlene's discussing. would have been just sort of a statistical average of how many people at any given moment are 90 days away from release, how many of them potentially would be Medicaid eligible, and how many of them are also, as we sort of take our average incarcerated person, X percent likely to be on medication, Y percent likely to be getting sort of treatment, Z percent likely to have to go to an ED during any 90-day time frame. And then, well, I used X, Y, and Z. Now A% likely to, to be 90 days out.
So for folks, this is only for sentence folks.
Yeah.
It's not detainees. It's only for those folks that are sentenced, because you're not detainees. Okay, anything else on this one?
I don't believe so. The other ups and downs, which are mostly downs, we've discussed them before with the group. So that brings us off the ups and downs then to the first of your questions.
I've got
Do you wish? Okay.
I've got a question on the 23 that's down. For,
Meeting. WCA.
Yes.
yeah, are you stopping those ads?
No, we're not stopping them. We just reduced some of the funds for them. So we have two separate campaigns, both of which are still going, one of which has been slightly reduced.
I'll still see you. on those.
Our most recent ad just went live
In the evening.
today. So hop onto WCX's website and get.
All of a sudden, there's a voice coming out of the living room that I know. Okay. Let's keep going on our questions then. We appreciate the work you've done on this, because I know that probably took a lot of time.
Thank you for that. And many of these were questions that I was happy to sort of see and learn as well. So thank you for honing them. The answers here are sort of where, our total staffing costs, just under 88 million. Regular pay constitutes 70 million of that. Facility staffing regular pay is just over half of our total regular pay at 37 million. But then we get into some real change, some discrepancies or disparities or places where the proportions go out of whack with regard to our total overtime costs being 17.5 million, and our facility overtime. Again, facility regular staffing is just over half of overall staffing, but our facility overtime is 90% of our total overtime costs, which makes sense. We are our central office team is incredibly dedicated and works their tail off doing really impressive things. I think you all know the kinds of hours that Haley puts in, but not all of our central team gets overtime, and those who do don't get it in nearly the rates at which, not rates as in pay, but rates of time that our facilities do. Mr. Howard left, but he would be the first to acknowledge how much our unionized teams at the facilities are doing overtime. The vacancy rates are there and are sort of broken out by parts of the department. And then we have some information about travel costs, which was something that this body requested information on. 90% of those travel costs, I think, travel sometimes sounds as if it's perks or training or, did we send members of the team to that conveniently located conference in Honolulu? And that is not the case here. Our travel is for folks that are doing work, either filling in at facilities that are far-flung or hospitalized prisoners and staying with them.
What do you mean facilities that are far-flung?
Our COD team or Central Operations Division, which is the hospital unit, their primary role is to take over hospitalized prisoners so that staff from the facilities don't have to do that. But a secondary role is when a facility is specifically under. An example would be our facility, Northern State Correctional Facility, had a real staffing crisis. It's not out of it entirely yet, but we were for periods of time detailing COD members who are called COSs central operations specialists, we would send them to Northern to work. If that individual resides in Wyndham, and we are asking that person to travel to Newport to do, 3 10-hour shifts in a row, we're going to offer that person a hotel in Newport. And so that's what that means.
So for folks, I'm sure for anyone who has gone into any of our medical facilities for appointments, you sometimes run into folks who are incarcerated there with a couple officers.
Mhm.
Sometimes they're just there for appointments. Other times, if someone is a patient in the hospital, do we have, we have to staff that room
Yes.
with a couple correctional officers or staff,
Sometimes one, sometimes two.
depending. How often do we have our folks who are incarcerated admitted into a hospital for a length of time?
How often? I don't know that I can give you that number off the top of I know that I cannot give it to you off the top of my head. I can give you some information about the rates at which we are sending people to the ED.
Yep.
So, well, here, hospital coverage, actually, I do have some of this. Hospital coverage for January 2026, there were 21 hospitalizations. What I don't,
Unique or people or?
21 hospitalizations. That could be the same individual going 21 times over the course of the 31 days. Doubt it. But that's how many there were. I can't tell you how long each of those were, right? That could be 21 unique individuals being in the hospital for the entire month of January. I know that was not the case, but that would be the outside case. 86% of those were covered by our central operations division and not by the facilities themselves, which is a really terrific invention of the previous the previous corrections commissioner, and really the brainchild of our current chief of operations, Travis Denton. I do have median days was 3 and longest days was 13. So that gives us a sort of a range for those 21 hospitalizations. And that's the average monthly since 2023 is 19. So January 26 was a little bit above the average.
So with our aging population and our sicker population, this cost could be increased over time.
This travel cost, you mean? We don't see it diminishing for the time being, owing again to the staffing problems that we saw in 25 have not been calendar 25. We hope to make inroads against them in calendar 26. And those staffing challenges would affect the rate at which we get the rate at which we use travel/hotels for coverage on the floors. With regard to hospitals, no, I think that we probably are going to continue to see our population age and potentially need hospitalization more often. That said, I also feel, as I've said before, I think we are going to see a shift in this calendar year with regard to the number of detainees that we have. And the detainees tend to be have some, illness issues as well, especially earlier in their stays with us.
Kevin?
You're coping with shortage, roughly 12.8% in staffing.
Mhm.
I mean, you're making it happen. Is this a normal amount of vacancies, or is this up or down from recent past? I mean, is there something we should be aware of or thinking about so that you can accomplish the tasks?
Yeah.
I mean, that's what overtime comes in to fill the gap.
Yep.
This and that. Anything we should be thinking about with that vacancy rate?
So from recent past, this is a drastic reduction. The overall, the department had gotten to the point where it was closing in the about a third down at its worst point in recent past. And by recent, I mean the last 3 to 4 years. But this is worse than we were prior to the pandemic, where I think that 12.8 would have been, we were in the single digits overall for the department as a whole. And so we have been better in the past. We have been far worse in the more recent past. We've made great strides around that. And now the question for us is, how do we move past this? We've been sort of stable at this level for the better part of the previous calendar year. How do we continue to move in the right direction with regard to bringing people aboard? Components of that are, I think that the biggest thing that the department did was creating experience officers their facility experience officers who are in charge of working with not only our current folks to keep them retained, but also focusing on recruitment and how we hire. They run the social media at those facilities. They're just there to promote various forms of wellness for our staff. Those positions are really important. Certainly, we're happy about our work with WCAX. We did draw back on that a little bit. That's an austerity measure, but we still have that contract because we need it. Whether it's whether you want to hear my voice coming from another room or some other piece, we do want that tool to be sure that we're getting out our message and finding new employees. How we get past this and move so that we can't. I would love to be back here talking about single digit deficit of staffing. And heck, I'd love us to get to a place where we're 100% staffed. I don't know that the department was ever 100% staffed, but we definitely want to continue to make progress on this. How and I think the things that you already do as a committee are tremendously helpful to us. And among the biggest, I think, is a sense of support for the people that do this work. They're like any people. They like to know that what they're doing matters and that what they're doing has been recognized for the importance that it carries.
Because the word is acute, and to me, that says there's pain as opposed to normal. Whereas the staffing shortage is most acute.
Yes.
Tells me you're in trouble, as opposed to this is normal operating procedures, and you're never going to be 110% because you're not authorized.
Well, that word was I think that was the committee's word. So
That was our question to them.
yeah.
Yeah, I know. That's why. Good. Thank you.
Anything else on the staffing issue? Okay, keep going.
So the next set of questions that we attempted to answer for you had to do with WellPath and the scope, et cetera. Those. What is in scope versus what is out of scope? And really, in scope we do a tremendous amount of care. It's really when a person needs a level of care that is equivalent to hospitalization. That's where we move out of WellPath and into either an ED or, as we were just discussing, the potential for being hospitalized for some period of time.
So I have a question. Is DOC ever asked to go into our healthcare committees to talk about what services they provide for WellPath?
No.
Because I was approached by some members of the healthcare committee here upstairs, and your budget for WellPath is how much? 40 million?
40-something million.
44 million.
44 million. And when they saw that number, they were stunned because they thought it was just providers. And they were concerned that we're paying the providers within WellPath much more than the providers in the community. And I said, well, they're offering healthcare across the spectrum.
They being these other entities or WellPath?
WellPath.
WellPath,
I
yeah.
said they're offering medication, they're offering MOUD, they're offering mental health. They're doing WellPath pays your local ambulance service to transport folks from the facility to the emergency rooms or to a hospital for inpatient care. They didn't realize any of that. They thought it was just paying doctors. They didn't realize that it really covers the scope of healthcare for the whole population that you're incarcerated. So it was quite an eye opener for that. So I just asked
Yeah.
that question.
They've never asked us in, but I do believe some members on my committee are on joint justice oversight. So it's concerning that they may not have known that information. What we've had will happen many times.
Yeah, there's just a real disconnect in understanding the healthcare that's being provided in DOC. And I think there is also for some folks a misconception in terms of our infirmary and what the infirmary really does, or can't do, that type of thing. So WellPath and the cost, I know, is starting to raise some eyebrows in the building. Be it in the healthcare committees, even in appropriations, when you ask for the increase in BAA, you know, it was $8 million for WellPath, basically. Was it 8 total?
Yes.
Six. 5, 6, and they were just stunned. So, well, it's healthcare. They don't realize how much healthcare is being provided in our.
It's healthcare and the ADP. It was the average the daily population is what really drove it. Yeah, I mean, certainly we would be happy to be called. We are happy to answer the call from any committee and talk in front of any group at the People's House to answer questions that the people have a right to know.
I think, I'm just giving you a little warning because I think probably next year, because the cost will increase, there's going to be a little more focus from other legislators on why is it costing so much.
Yeah. We certainly are interested in making certain that we're using taxpayer money to the best of its ability and not misusing any of it. That is our ultimate goal. It's the governor's clear goal as well. So if we could find either a different provider or if we could tweak the provisions that we do have, we are very much interested in looking at that. We feel confident that what we're currently getting from WellPath and the relationship that we have with them is a fair one. But there's always room for improvement and renegotiation. There's also a strong argument to be made by our partners that we're asking more and more of them, and we are asking things of them that other similar departments don't ask. And so that comes into play as well.
Well, there may be more scrutiny in the upcoming years. I just want to give you a heads up because I think it's just a lack of understanding in terms of our population that's incarcerated and the needs and what you need to provide.
Yep.
Okay.
The performance metrics are listed here around accreditation, around the notion of various kinds of ways that we can get money back if there are omissions or problems. Money that they save, and this is very important, money that they save goes back to us, not to them. So in other words, there is not a what we wish to do is remove any sense that there is an incentive for failing to listen to an incarcerated person or detainee when that person says, I need a certain kind of care. I need to go to a hospital. And going to a hospital is additional cost for WellPath initially, the transport, et cetera. We want to ensure that our provider is never saying, you're fine with this, you know, your stubbed toe is not broken because we don't want to deal with a higher level of care than we can provide here. And therefore, we're going to save the money by not sending you to the hospital because that's good for our bottom line. That is not a component of the contractual relationship, and that's purposeful. Oversight through our central office and a dedicated team that works closely with WellPath and also is aware of what we are expecting from them in the contract. We also have an elaborate both medical slip process for people inside to make medical requests and a grievance process when they don't get what they have asked for or are not satisfied. That's important too, because it's an additional layer of oversight through our legal department.
Well, you're saying alternatives considered. You said they've considered alternative providers in bringing care in state. How long ago was all that done? Was that done recently?
I will have to beg that off and ask.
The last comprehensive analysis we made around bringing care in state was around 2024. Which I think is the same year that we approached some providers in the community about the potential of partnering with them. The WellPath contract, they started either in 2023 or 2024, and obviously through the RFP process, I've considered other providers.
And that's happened before. Gone out to the community and they just, and we've even reached out to UVM and the medical school up there and they said no.
No.
There was no interest.
Yeah.
Moving on then, with your permission, ma'am, to the associated questions around electronic monitoring that were posed. Sort of an overview of our monitoring. There's three kinds. There's GPS ankle bracelets. There are something called scrams, which actually monitor alcohol as well by the skin and can determine whether or not somebody is using that substance. And then there's just a field link, which is a much lower, it's essentially telelink and you call in. The total costs for GPS is about $1,200 a year. The total cost for Scram is about $2,000 a year, and both of those can be compared to about $114,000 a year for incarceration in the state. So those are obviously, when we can use those tools, we want to be able to use those tools.
Can I jump?
Sure.
Can you give me a sense of how many folks are on GPS and how many folks are on Scram?
I can find that for you. I
And would
don't
those
know.
costs go up if we increased? Like, is that a fixed cost or is that per?
It is fixed. It's based on the units. And so there's probably some nominal savings if we were to purchase a great number more units. There's actually a savings with the Telelink. The Telelink service does decrease the more people we have in it. But it's a much, much smaller cost overall than Scram or GPS. So right now it's a relatively fixed cost owing to the units. And I can hypothesize that if we suddenly said, we don't need 300, we need, 1,000 units from you, we could probably renegotiate some slightly reduced cost.
How is Scram applied to the person?
It's a bracelet. It too is a bracelet, and it reads a person when you drink alcohol, it comes off your skin.
Yeah.
Right?
I was just curious about the annual figure that you cited. I believe you said 114 grand per person per year in our facilities. And I've heard different outfits quoting different numbers, right? And so this is current and this is for the Vermont facilities?
Yeah, later in this document, you'll see that we
Okay.
provide a piece of information that says it's $303, that $313, that in-state is $313.69, and times 365, it's
Right.
approximately 114K.
Thank you.
The out-of-state is a third of that. It's 103. So that's 38K per year for the out-of-state. But I do want to note that our in-state per person cost does not decrease with out-of-state. It actually technically goes up because our in-state cost is fixed by the number of facilities we have. There's some nominal decrease in food. There's some nominal decrease in ADP with regard to WellPath. We avoid penalties by having more people than we're supposed to have. But overall, the bulk of that cost is our staff who work the facilities and the infrastructure of the facilities themselves. And that does not change when we send a person out. So, we don't reduce the 313. We don't reduce the 313 per day by sending people to the place where it's only 103 per day.
And we're not, and a lot of people like to compare those two numbers.
Right.
Say, well, it's so cheaper out of state, why aren't we doing it? But you can't compare because you're not comparing apples to apples.
It is not. The cost of living is vastly different. The size of the facility is vastly different. The economies of scale that our partner CoreCivic realizes are vastly different. And then the other piece too is that the people who end up going out of state tend to be stable, healthy individuals. And that too has an effect on what we.
And you don't provide the programming down there as you do up here. It's not cheap.
Not as much, but we strive to try to make that as fulsome as possible. Not fulsome, as full as possible.
And Joe?
So I appreciate that distinction, Commissioner. So the only way that you would actually be able to affect that 313 figure is if one of the facilities in Carter Hall were closed. That would be a systematic change.
Yes, if we had fewer people, and that is staff, if we had fewer staff and less overhead, that could change that rate, but it would also potentially increase it initially. There could be a real change in the per person, so, yes, it's largely fixed by the costs that we have.
But short of something like that, your costs are largely fixed, I understand,
Yes.
by facilities and staff in those facilities.
And I just want to make sure I heard right. So the annual cost in state's 114,000 per person.
313.69 times 365 is just under, I believe, it's approximately 114.
And out of state is 38.
Out of state is 103.59 per day, and again, times 365, that's approximately 38K per year.
Yeah, slide 11, Kevin, I accidentally jumped.
Say again.
I asked my question too early. It's
Yeah,
slide-
this is
slide
all on
11 is the
page
beginning.
11.
I thought I heard it. I just wanted to make sure I heard the right.
You did.
But you can't compare, you can't compare them because it's not apples to apples. That was what was just explained. I know it's very seductive to say, oh, well, then we can ship folks out of state and save a lot of money. But we're sending the healthier folks out there. They don't have as much programming. And there's a larger facility, so the cost is spread out.
Yeah.
For more.
Vendor versus staff, portions back, I apologize, back to the questions about electronic monitoring on page 7. Vendor versus staff cost is difficult to sort of outline. Our staff costs are personnel and what they do. The vendors are parts of contracts, and it's not an extra cost. It's a contract with the vendor for providing the tools. We provide the monitoring of the tools. And then how does it reduce facility use? Well, again, if that's not a determination made by DOC, of course. This is a determination made generally by the parole board or by the court in the first place as a probation measure. So that they would say, we're not going to incarcerate you at all. We're giving you probation, but it's a probation that involves either GPS or Scram, or the parole board says we have determined that you can be out and about in the public, but you're not ready to be out there on your own yet. So here you go and you get monitoring. And then that becomes the burden of our probation and parole staff who are really good at this work. But it is a way to have fewer people in facilities.
But, and I don't want to get into the weeds of electronic monitoring. There's active supervision of electronic monitoring and there's passive.
That's correct.
And the difference is active shows actual time that something may be happening and there's a response there. Passive is you might find out the next day that they violated something.
Yes.
So that's the minutia. You don't want to get into too much.
With your permission, moving on to food services and associated questions on page 9. Okay, wait, I'm sorry. There are some ups and downs on page 8. My apologies. Move through it. These are operating expenses. We did discuss these ups and downs previously.
Okay. So some of this is like I'm looking 2.2 million for ADS. That's part of all your IT systems.
Yeah, that's our charge, service level agreement.
Software licenses. While we're into software and IT and ADS, where are we in terms of your whole electronic system upgrade, your IT system upgrade? We tried to get you money through the broadband board,
So Wi-Fi.
Wi-Fi.
Yeah, it's a great question, Chair. We've set up meetings with ADS that are bi-weekly as a check-in on the project, and we're currently working with them on an updated cost estimate, which they believe should be relatively easier to do since they've already done a very comprehensive one that they kind of update from the changes, of the last couple of years.
So we were, what dollar figure last year? 3 million?
Yes, around that. It's slightly higher now, 8%.
Only gonna go up.
Yeah. That's true.
That and your air conditioning. So your two biggest infrastructure upgrades.
And then women's just.
Well, and the women's facility, which we haven't talked about so far. Okay, anything else on this chart for the committee? Let's flip it to food service.
The question was, does the Vermont DOC use an in-house contract or hybrid? It's a hybrid model for our food services inside our facilities. We contract with Trinity Services Group, and that includes meal planning and recipes and training and inspections and dietitian services and making certain that caloric amounts are sufficient, making certain that we have, for example, food that is provided to people. It's Ramadan, and we need to make certain that we provide food both before and after fast in ways that are accessible for folks who are observing religiously. We also need to ensure that the caloric intake is good once the period of fast is over. So that's one example of religious diet that we work on and ensure we provide. We have two primary food vendors, Reinhardt and Prime Source, but we also have partnerships with local farms, food processors, orchards. We harvest from our facility gardens. Our facilities tend to have gardens, and people can grow food that actually gets served to other members of the facility community. This is a place where we have found a little bit of common ground with the federal administration through the MAHA movement and the ideas about improved food and local grown food that was applicable, and I believe it was a component of the Rural Health Transformation Grant. We talked a little bit about that. We as part of AHS, we contributed to the state's application to that grant. Obviously there are many places, especially with regard to things like vaccination, et cetera, where we don't agree with that movement, but it's a place where we found common ground. With regard to performance standards, we have inspections, et cetera, through the services, and we have also that grievance process. And so I know I sign all those grievances once they're reviewed by our legal team, and a fair number of them have to do with things like I did not get an extra serving, or I feel that I did not have enough of this or enough of that. And so we have a review and a process for assuring that we're meeting those standards as well. So that's, I think, the bulk of that page. Page 10 is another set of ups and downs for specific to justice reinvestment, and then some out-of-state services, et cetera, and changes there. The big one that you see first is the $100,000 of forensic, but that actually is sort of a wash. It was moved just to a different line.
It's for mental health, it's Department of Mental Health.
The out-of-state amount, which is there in section B 339, that was increased because we did increase the number of people out of state. At the beginning of the calendar year, we had about 120 or so. We now, and that is the number that it had hovered at about that since the pandemic. Prior, 10 years prior to the pandemic, or not 10, but the 8 years prior to the pandemic, there were as many as almost 500 out of state, but we had gotten to a place where it was about 100 to 120, and had been for the better part of half a decade. This year, we sent the first very large transport that we had in the better part of half a decade and sent 30 people down. We currently have just 150 or just over 150 out of state, and that required additional funds. Our agreement with CoreCivic allows us to have a total of 300, but we don't pay them for people that aren't there. So we had to get additional funding owing to the fact that we did send 30 people out of state to increase the population down there from 120 to 150. If we were to send more, we would also have to find additional budget. It is not currently our intention to send more, but it is a valve that is available to us if we see population increase the way we did in calendar year 2025.
So this 4 million is on top of what?
That's it. That's
it.
it.
That's it?
Yes.
That's it.
So it's 4 million and you're anticipating, is that based on about 150 beds? What's your anticipation?
Yes. That is based on maintaining a 150 beds out of state.
So I'm gonna throw you a curveball. You know what's rattling around this building? It's a forensic unit
Mhm.
that would be in a wing in a correctional facility. We don't know what the numbers of folks would be. But how would you absorb those folks in a wing in a correctional facility? Would it put more pressure to move them out of state?
We don't currently see it as absorbing additional people. The folks that are specifically addressed by the forensics bill are people who are already in our custody. So, for example, in the past half decade, there have been 9 really horrific murders in the state of Vermont, allegedly committed by 6 perpetrators, all of whom meet the definition described in the bill that's been proposed. These are individuals, these 6 individuals who've been accused of these very horrific crimes are currently not competent to stand trial, but they are in our custody. They are all being charged with crimes that are, for lack of a better term, capital. We don't have a death penalty in Vermont, but they are crimes that could result in a life imprisonment. They're in our custody. What we are not currently doing as we hold them in custody is attempting to restore that competency in any measurable or specific way. And what the forensics bill really envisions is a process by which that attempt at restoring competency is made. We would therefore have to contract with some provider. WellPath does provide similar services in other states, but that's not something that we've yet breached because the law is not yet made. There would have to be a mechanism whereby a failure to achieve competency were evaluated and then reevaluated. Is this, something that could be indefinite? And there are situations where it might be. There are also other situations, such as people whose competency hinges on issues around TBIs, traumatic brain injuries, or competency hinges on issues around developmental delays that are not really things you can restore, and we're going to have to sort of grapple with that. But insofar as the change to our population, we don't actually see it as one. What this will do is it will remove some of the current sort of yo-yo effect of people who are charged with these horrible crimes, have not yet been convicted of these, and may never be convicted of these horrible crimes, but also are not currently competent to stand trial. The yo-yo effect is that they sometimes are in our custody and then they can get moved out and then they can get moved back. This solidifies it and says, no, the place where they will stay when they're credibly accused of crimes of this nature is with the Department of Corrections. And the Department of Corrections will then participate in some mechanism of attempting to restore competency. It is not up to the department, or should not be up to the department, to evaluate that competency and determine it. That is a court determination. But providing the medical treatment, and by medical I mean therapeutic and psychiatric, but by providing that kind of treatment in order to get a person to return to competency, that would be under our aegis. It's not a change. We don't anticipate there being new people, and we don't anticipate using any kind of different facility. These are people who would be housed as they currently are, as again, all 6 of those individuals accused of those terrible 9 murders in Vermont over the past half decade are in our custody now and don't require a specialized wing. We keep them in sometimes specialized unit in different kinds of housing, but not by themselves and not with other people that are accused or sentenced and who also have mental health issues.
So I'm going to lay the groundwork because we'll be getting into that after the end of March.
Yes.
We are working April.
Yes, ma'am. Well, then moving to page 11, which we actually sort of already basically tackled, which is the out-of-state contract and the nature of it. It is, I do want to note what's in that sort of smaller text next to the square inner bullet. Even with the contract, we are currently looking at 150% of Gen Pop beds in our male facilities and 130% of Gen Pop in our female facility. And that is really striking. That is not the same as saying that we're that far over total capacity, but it means that we are well past what the profession recommends, which is 80% of Gen Pop beds. That is what you want. You want to be at 80% of Gen Pop. Right now, for example, at the facility in Mississippi, we are at 50% of our allocated beds. And that means that everybody there has a single cell. And that means that we are able to, what we don't count in that bed count, for example, is the fact that at any given moment, some of those individuals in Mississippi may have to be in specialized housing because they've committed disciplinary infractions, or in the infirmary because they have had a medical event that can be handled inside the facility. We don't want to count those specialized beds as beds because we need them available for when these unique situations happen, disciplinary issue, health issue. That's why we really want to maintain 100% or less of our Gen Pop beds. And we are well past that in our facilities.
That's why we ship folks out of state.
It is, but even with that shipping, we are still where we are with regard to we are over capacity or underbuilt.
Creating the pressure on that is the high number of detainees.
That is correct.
What's our number of detainees today? Ballpark.
Oh, it's not a ballpark. I can tell you the number. Although,
It's
653 total.
yes, thank you.
It's going up, not by 10 or 15, but by 50 and 100.
Well, on Friday, it was at 646, and today it's 650. So we are seeing it increase. The women's facility is back over 180 for total population, which is absolutely shocking and untenable. So Representative Hedrick has asked this question before, sort of what is our line? We don't have a bright line, but I will say that if we spent the entirety of March at 180, we would have to drastically think about how to reduce that female population or move parts of that female population. So, staying at 180 for any length of time is not acceptable with regard to what we want to provide insofar as safe, secure, and compassionate housing.
Good.
Moving on to 12. Some additional, well, actually, there's not a lot of activity on that one. I don't know if it's about the offender work program, if anybody wants to talk about it. The bullets on the following page 13 get at some of those questions. And we can talk a little bit about what we were not certain about the data that we provided you in the last meeting, but we are now.
Well, we went for a new budgeting system in the state. And we think in the budget system that used to be was Vantage, and then the new one's Adaptive. There were two positions that in November, if you don't use your positions, they sweep them and they take them back to the hiring pool for the whole state. 2 positions out of that 4 were taken in November. We think it just didn't make the cutoff for Adaptive, so that's why the reporting was off and showing actually the amount for 4. I checked with AHS Fiscal, and our payroll system only shows 2 positions now, which it should, because the 2 were swept away. So that's why the reporting for the payroll was off. We think it was between the switch from one system to another and the fact that the sweep took place sometime in November, towards the end of November.
Those 2 vacant positions were pulled completely
Pulled to the pool, and that's a standard process.
to the vacancy pool.
Yes, for the whole state.
So the money still goes with them?
Well, it should go with them, yes. So even though it reports it at that amount, the reality is we don't have that because that's controlled by the Department of
But
Finance.
that's calculated within your budget?
It shows it in the budget, but because we don't have the positions, that means that the payroll, that money did slide over to,
To the
yes,
vacancy.
with those positions.
And I think, sure.
So the money's still there to spend if you had to, or it's been transferred to.
It's been transferred. It just shows it in that report and in the budget. So it's really not correct.
And that is, now, again, that did not get at every single question that was posed in that
Did a
document.
I appreciate the work that you did. So it was a lot of work.
So I would ask if there are things that we did not get to that you really do want to know, could you flag those for
Yep.
us?
Yep. We can do that. I think folks are a little fried right now.
I don't blame them.
But this has been very helpful. It's been, I really do appreciate the work that you did to answer those questions.
I sort of need a remedial ignorance picture here. So those two positions and the money associated with them were swept in November to some level that I don't understand. So where are those two positions
They go
now
to,
listed or available or whatever?
they go to the state level. So what the state does is any positions that sit vacant for any length of time, they take them.
Yeah.
Thinking that you don't need them.
Yeah,
And then those positions and the monies go to the state pool. So when the people ask for positions, if there's any available and they decide that they're supposed to have it or whatever, they go through that process. But they're not ours. They were actually taken.
thanks.
Anything else? Because we're gonna break for lunch and then be back here at 1 o'clock. Talking about telephone communications within DOC. DOC's been living in our room here for a while.
But just a reminder, we're gonna be in House Judiciary at that time, so I'll come over as soon as I can.
Yeah. And John's got a new draft that he's gonna.
Yeah,
look
it's
at.
thank you.
But,
This job.
no. Our legal-
I was like, I don't know.
He's felt the same way, but he's our guy. After, when we get back here in March, we'll have 1 week, the first week back is crossover. So any policy bills that we have to get it out by the end of the week. After that, DOC won't be in here as much because we're gonna shift gears to the capital bill. Then,
We say our goodbyes,
and then once the bills get over to the Senate, you may end up spending more time over there, but we don't know for that.
Just see.
Chelsea. So let's break and we'll be back.